Hi, everyone. Welcome to the fifth webinar in PASSERELLE's webinar series for this year. And we're so pleased today to be joined by Dr. Ambreen Sayani to discuss with us critical patient-oriented research, a fundamental shift in patient engagement. And before we begin, if we could just move to the next slide here. Just want to take a moment to recognize that PASSERELLE's central office is situated on what is known as Quebec City, on the traditional unceded territory of the Huron-Wendat people, the Innu, the Malasite, the Atikamekw, and the Abenaki people. In the spirit of and respect and reconciliation, we extend our gratitude to these nations for their stewardship of this land. And I want to recognize the lands from which all of you may be joining from today as well. And just before we dive into the webinar today, just want to give a shout out for our next webinar coming up on November 26th. And we're very pleased that Dr. Stuart Nichols will be presenting on the 3 R's: recognition, remuneration, and reimbursement of patient partners in research. So if we should be circulating that information shortly, and hopefully we'll see many of you there as well. And so today, as I mentioned, we're very pleased to be joined by Dr. Sayani. And just as a housekeeping note, so my name is Rob Van Horn. I'm the operations manager for PASSERELLE, and I'll be hosting today's session. And we'll have an opportunity at the end for some questions. And so please feel free to use the chat to ask your questions there, and we'll be able to pass those along and get those responded to. And so Dr. Sayani is a physician, a social scientist, and policy advisor. She is an Emily Stowe Scholar at Women's College Hospital in Toronto, where she founded and leads the Improving Cancer Care Equity, ICCE lab at the Women's College Research and Innovation Institute. The ICCE lab works to improve cancer outcomes across population groups by promoting equitable access to prevention, early detection, and high-quality care. Dr. Sayani is an assistant professor at the University of Toronto's Dalla School of Public Health. She serves as health equity advisor to the Canadian Partnership Against Cancer, co-chairs the G7 Cancer Inequalities Network, and co-initiated the Equity Mobilizing Partnerships in Community initiative. She has received multiple awards recognizing her leadership, research, and innovation in patient engagement, including the CIHR SPORE Transition to Leadership Award. And we're also grateful to her contributions to PASSERELLE and helping to advance our mission and work as well. And so without further ado, I'd like to turn it over to Dr. Sayani.
Thanks so much, Rob. I'll be sharing my slides, and we can probably if you can confirm for me that that's working on your end as a slideshow.
Yeah, we're seeing the screen now. So just need to put it in presentation mode, and you should be all set to go there.
Perfect. Does that work for you?
Yeah, we're seeing that there now.
Okay. So hello, everyone. It's a real privilege to be here today. I am a huge fan of what PASSERELLE does in terms of building capacity for patient-oriented research across the Canadian health research ecosystem. I am here in my capacity to share some of the lessons that I've learned in the field, but honestly, I'm hoping that this will lead to a conversation where many of us have different areas of expertise and experience, and it can lead to a joint conversation later. I have built this presentation with the assumption that everyone has either had some experience with patient-oriented research or is interested in doing patient-oriented research. To start us off, I am going to lead with 3 reflective prompts. So this is the first one for you. And this is about the idea of empowerment.
Oh, sorry, Ambreen. Just one moment. Just seeing
Mhm.
that is it possible to share? We're seeing kind of the behind the scenes screen. If we could
Ah,
change
I
it just
see.
to the main presentation screen.
Let's see if that works. Wonder if it's glitching on my end. Okay, let me stop sharing for a second. Okay, from current slide. Let me know if that works. Does that work, Rob, or is that still in presenter view? Oh,
Yeah, it's still in presenter view. Just wondering if
oh, that's
the
funny. What I can do is I can send you my slides if you'd like to just, I wonder what's happening because I don't see presenter view on my end.
yeah, I'm just gonna ask Jessica if you're on the line, if maybe you can share that, or if you can help Ambreen get it to the right
Or
mode there.
if if we aren't too many people, I can just, does it work if I share it this way and I don't use slide view? I know it's not ideal, but if if you would like to do it that way, it's up to you, whatever works.
Sure, you can send me the slides, and while we're waiting for me to put them up, you can start sharing that way. But we can see more clearly this way as well.
Okay, so let's just troubleshoot. I'm sorry, I don't understand what's happening with my computer. But we can keep going this way if that's all right.
Yep, that works, sir.
Okay, so I want to start by just building in 3 reflective prompts. And I would ask everyone to just think about the ways in which they have engaged or been engaged in a research project that involved people from the public. And when we talk about empowerment, as a patient-oriented researcher, very often the power of a project lies with me as someone who has received funding for a project, has initiated a project, and therefore I can invite people into my project. So my question to you is, when we talk about empowerment and we talk about empowering people to contribute to a project, where does this idea of power even come from? And is it our objective to hold power and then to invite people through empowerment into that project? And does that actually shift the locus of control? My second question to you is about influence. And when we do have people that have been invited into a project, how often is it that they're actually able to influence change? So if empowerment is about locus of control, influence is really about the locus of change. And having people within a project that are able to influence the outcomes. And this can be at a very micro level, whether it's something in a hospital related to the ways their processes work. It can be at a regional level, and it can even be at a national policy level. So what is the locus of change? And people who are involved from the public, are they actually able to influence the locus of change through their influence? And my third question to you is really about the idea of authenticity and the flip of that being tokenism. When we involve people in projects, which parts of their identity are we building our structures up to for them to engage with and bring and to be able to voice with full authenticity? Or do we ask them to leave certain aspects of their identity behind because the locus of action in our project can't really shift in order to accommodate those different aspects of their identity? So I've asked you to think about empowerment. I've asked you to think about influence. And I've also asked you to reflect on authenticity and tokenism as two sides of the same coin. And with this, I'm going to introduce you to the idea of critical patient-oriented research, in which we actually think and contest with these issues on a day-to-day basis. I want to caveat by saying being critical doesn't mean to critique. There's a huge difference between critiquing something for the sake of finding issues or problems versus being critical because you want to improve what works well. And when you reach a new state of working well, and you've reached a status quo with what's working well, to be able to question it again and say, well, now that we've reached here, what can we do further to make this even better? And it's a constant state of betterment. So being critical is about this constant strive for doing things better. And in the context of the work that I'll be talking to you about today, it's about being able to shift power so that it's not about me holding power and empowering others through my project, but rather power sits between the group because everybody holds power, and shifting it between different people within the group so that we can reach common aims. It also situates research as something that is highly relational and not transactional or project dependent, but also structural because it considers how people are experiencing engagement with healthcare, engagement with health research, and ultimately the factors that influence their health outcomes. So I'll do this today through these four dots are the outlines of my talk. I'll tell you a little bit about who I am, what I do, how I go about the research that I do, and the why that keeps me going. So as a critical qualitative researcher, it's really important for me to begin with my positionality. And I will start by situating myself. I am a person of South Asian descent, and as you can see on this one very, very busy slide, that begins actually with my paternal grandfather and my maternal grandmother, whose lives were actually cut quite short because of colonial violence. I am a person who's 2 generations removed from my own homelands. My parents, who you see in this picture, and my sister and I have immigrated and moved across many different countries, and I'm proud to call Canada my home. I also want to situate my work. I began my career, and this slide really ages me, but that's part of being a qualitative researcher. Every experience builds you up, and it becomes part of your building blocks of your fabric that form who you are. I started off thinking I can deal with the world's issues by being right on the front lines and providing care to people when they most need it. I trained as a surgical oncologist, and in doing so, I was at the point of clinical care where people were coming to me as a tertiary level care provider, meaning they had already gone through their primary care provider, probably spoken to many different family and friends, and had a very good idea of what was going on with them. When they came to me, I had a toolbox of maybe 3 or 4 options that I would discuss with them in that clinical encounter, and then talk them through those next steps. The more and more time I would spend with people downstream, I began to realize that their lives are actually very complex, and that the tools in my toolbox were not necessarily what they needed in order to have a good health outcome. So what you see across the rest of this slide really is my journey, progressing from talking about the gaps that I was seeing in clinical care, the ways in which we could address them, and then building a community of people from the public and policymakers to come together and talk about these issues so that we can have what I call collective problem posing. Do we all agree on a problem? And then, as a secondary step, deciding on what is a collective problem to be solved or problem solving. I am a critical theorist, which means I understand that socially and historically inscribed relationships, societies, economic assets, the ways in which we live our everyday lives influence who we are today. We cannot be devoid of the past that has created our present, and that there isn't a single objective truth, and we need to create spaces where many different people can come together so that we can listen and learn from each other. I also believe that mainstream research that doesn't constantly challenge the status quo, and this includes constantly challenging my own body of work, reproduces mainstream oppression. But part of my work is taking action. I don't want to sit on the sidelines and describe what's not working well, but rather I want to work with a community of people to think, well, what can we really do about it? And how can we do things better? And as I mentioned before, once we reach that better, what's the next level of better that we need to get to? And this is where I want to situate my land acknowledgement now that I've told you a little bit about myself, how I view the world, and what I am and who I am and how I come to this land. I live in the city of Mississauga, which for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this is the meeting place and still is of many Indigenous peoples across Turtle Island. I am a settler on this land. I am here because of colonial displacement that has led to multi-generational oppression in my family. But I'm also privileged through a colonial informed identity to be living here on this land as a settler. As part of my goals and commitments towards truth and reconciliation, I am committed to repairing broken trust. And that means seeking out, building, and restoring trusting relationships with Indigenous people across Turtle Island. All of these things inform the body of my work and the what of everything that I study. It is structured within my research program, which is called the ICE Lab. I study cancer care because that is my own clinical training and it is where I have the most experience. But I bring this to a world of interdisciplinary research where I partner with people from the public, I partner with policymakers, primary care providers to really question what's happening across the cancer care continuum. Are people receiving timely care? Do people know of services that are available? How can we co-create services to better meet their needs so that everybody is coming out with a better health outcome? And why? I think absolutely everybody in this room today has had someone who's been affected by cancer. In Canada, 2 in every 5 people will be diagnosed with cancer, and 1 in every 4 will die from it. But given current advancements in the way we treat cancer, it's increasingly becoming a chronic disease, and more than 1 million people within our country live with a diagnosis of cancer as a chronic illness. But we don't share this burden equally. Who you are, how you look, where you live, the resources that you have access to, the level of education that you have, the languages that you speak, ultimately all of these influence who gets cancer, who receives good quality of care when they're diagnosed with cancer, and even who lives and who dies with a diagnosis of cancer. And I'm going to bring you here to a quote by an American statistician, actually. And he put together the idea of quality improvement within different systems. So this quote is from him. And the idea being that every system is perfectly designed to get what it gets. So if within our current healthcare system, cancer care risk and cancer care outcomes are unevenly distributed, it is because our system is getting the results that it was designed to produce. So this is the issue, and we need to think about it a bit more deeply. For the rest of my talk, I'm going to focus a little bit more on lung cancer, because this is a huge aspect of my research program. Why lung cancer? It's the most commonly diagnosed cancer in Canada. It is also the most common cause of cancer-related deaths within our country. 2/3 are diagnosed at a late stage when there's no chance for treatment. And 2 out of 3 cases are related to a history of smoking tobacco. But to note that a history of smoking tobacco isn't as much choice as it is structuring by poverty and by geographic location. What's important to know is that we don't share this burden of lung cancer equally. In fact, lung cancer has one of the most unequal distributions of all cancers within Canada and globally. What you see on this slide is what's known as the lung cancer gradient. In a nutshell, if you're poor, the chances that you will receive a diagnosis of cancer is twice as high as the average person. For people who are First Nation, Inuit, and Métis, their likelihood of surviving lung cancer is a third lower than everybody else. And for people living in rural and remote communities, they're much more likely to be diagnosed at a late stage when the chances for curative therapy are far lower. Is this happenstance? No. This is a result of the ways in which our system is designed to produce this gradient, and it is our job to understand and unpack this gradient and to be able to respond to it. So how does this gradient in differences even come to be, if I were to take a bit of a theoretical sidebar? We have our social policies, we have public policies, culture, and environment. All of these aspects shape how people experience their everyday act of living. Where you live, the amount of income you make, the ways in which you're able to access affordable housing, how the education system meets your needs, all of these are structured by the policies, which then shape the social determinants of health. But at the very top of this are people trying to access care on this already very uneven state. My program focuses on the ways in which we can improve access to care. I have amazing colleagues who work on improving social determinants of health, such as housing and income and employment. And together, it'll take many of us to be working together in tandem to be able to reduce this gradient. But let's look at the case of lung cancer in a little bit more detail. What you see is a very complex slide, and I don't expect you to read all of it. But very briefly, what I described as the structural determinants are the ways in which our policies, whether they're legacy historical policies or the policies that we have today, have shaped how the social determinants of health are experienced for us on an everyday basis. But on top of this, we have our healthcare system, and we have what are known as system-generated inequities. What that means is, from every point of access to care in the healthcare system, we can either minimize the gaps in care or we can widen them. And if we go about creating care that doesn't consider the ways in which people access it, what we have is stacked inequities, which build up on an already unequal gradient based on the social determinants of health. And therefore, as people working in the healthcare system, we need to think about each and every one of these and consider how to reduce the stacked impact. So I'll take you in on one of these steps, for example, and this is inequities in access to lung cancer screening. What do we know about lung cancer risk and access to lung cancer screening? We do know that people living, for example, with lower income are more likely to be smoking, are less able to quit smoking, and are less likely to access timely care. So what happens is known as a double jeopardy. People living with low income have a higher risk of lung cancer, but then they're also unable to access timely care that could reduce their ability to live or survive with lung cancer. Lung cancer screening with low-dose CT can reduce mortality related to lung cancer by about 20%. But if we aren't reaching those that are at highest risk, we have introduced an opportunity to screen into the population, which perhaps is going to widen inequities for those that have the highest risk. So those are some of the problems that we grapple with. And it takes me straight back to the idea of systems design. When we introduce an intervention, we need to be extremely thoughtful about who's able to access it, who will be left out of that design, and how can we minimize the stacked effect. But we can change the issue into a challenge statement. If we know that there's a disproportionate burden of disease in lower income communities, we know that the interventions can widen structural inequalities already present. We know that we need to learn from people about the ways in which they access care, and we need to engage with people. Each of these switches from an issue to a challenge. And the exciting thing about a challenge is that it can be solved because it becomes an opportunity. And what we need to solve this is the idea of an equity promoting health system. So let me take you through a couple more definitions as we get deeper into this. Equity in health systems is about addressing the differences in access to healthcare between groups of people that are systemic, that are unfair, and that are avoidable. Fundamentally, what we're trying to do is to make sure that all people have the opportunity to have their healthcare needs met when they need it. And we can think about this across the 5 dimensions of access, meaning, does everybody know that a certain opportunity to access care is available? Is it acceptable to them in a culturally and socially acceptable way? Is it available at different times and places where they can access it? Have we considered the direct and indirect costs of accessing this care, including time off work? And ultimately, if people have accessed their care, did they leave with their needs met? So those are the different dimensions of access that we work on. And all of these build into what is known as an equity promoting health system, which rests on 3 pillars. It means we understand all those root causes that creates gradients in health outcomes. And we're actively working to minimize the stack effect of system-generated inequities. But fundamentally, we need to co-create care because that's how we will understand what would work better for people based on their lived experience. So this brings me to the body of my research program and how we go about it. Patient-oriented research, as I'm sure many of the people on this call are familiar with, focuses on including patients as partners on the research team. Our goal is to focus on patient-identified priorities, build in an interdisciplinary collaboration, and have real application to practice and policy because the relevant team has sat together and co-created a good research question with relevant outcomes that are rapidly implementable in the field. We also know that patient-oriented research has many benefits. Patients become active and informed partners in healthcare. There's a higher likelihood of accessing the right treatment at the right time. We have improved quality of life and improved cost effectiveness of the health system, to name a few. But now I want everyone to put on a little bit of a critical hat and think about the status quo. The status quo, where we usually ask people from the public or patient partners to engage with us on our research projects, includes a typical institutional environment, such as, for example, this hospital boardroom. We, as fund holders, I myself in particular, who leads research projects, can invite people into the research institutional environment along a table with many other different policymakers and providers as 1 or 2 people from the public to think about our research questions. Thinking critically, the questions we ask ourselves in this room are, who isn't here? Who won't come to this space? Why won't they come to this space? Where should I be to engage with them better? And in my own program of work, very often I've found that this institutional boardroom setting is the last place where people want to be engaged. We want to be meeting with people in communities, having multiple cups of tea or coffee with them to understand their lived experience, to understand what holds them back from institutions. Is it just because they don't know, because they don't have time, because they've been harmed by the institutions? And we need to build that in at the community level. We also need to think from an equity perspective. And this begins fundamentally by asking, for my research question, that I am exploring who is already experiencing the most inequities. And there are usually a lot of statistics that allude to this. Being equity-centered then means I build out my entire engagement plan around that philosophy and understanding. Who has been most excluded? And therefore, I need to practice relationship building and being in the community with people who've been most excluded. But this isn't from a transactional perspective. This is from a continuity, from a reciprocity, from a trust building perspective, because I'm genuinely curious about understanding their lived experiences and understanding how those health inequities are experienced so that we can build better care. And ultimately being power redistributive, because when you build those relationships along from community, what you want to do is to mobilize from the community in towards the institution, and therefore work with communities in spaces where they're asking questions and you are the vehicle of research that brings it back into the institution. So instead of the institution and myself asking questions and wanting to bring people in, it actually works the other way around, where communities have their questions and I'm the conduit of bringing that into the institution in a good way. But how do we do this in practice? And I'm going to talk to you about some of my work in the lung cancer screening space. What you see here is a very large group of people. These are the people who are involved in a stream in my program called the Lung Health Equity Stream. And this is who's here now towards the end of 2025. If I would have shown you this slide 6 years ago, it was just myself, 4 people from the public, and 6 health system partners. What we've done over almost 6 years of time is grown as a community. We have built in more patient partnerships, spent more time in community understanding issues. As we've done this, health system partners have understood the relevance of the questions that we're asking, and in fact, by invitation, asked to join the Lung Health Equity Committee. And we've built in capacity through training new trainees, including from the undergraduate to postgrad level. But how do we share power? Because a fundamental aspect of this is distributing power across the team. We, as a core research group, do this. We meet with the people from the public, we meet with health system partners, we meet with policymakers. The onus is on us to meet with everyone either individually or in groups and to bring together everyone. But this is possible because all of us have a united vision, which is to identify inequitable care pathways. We all want to co-design services that better improve access to care. And then we want to build accountability between everyone. But the onus of this lies on the core research team. And I have to admit that this is a lot of invisible work, but it is the work of shifting power through the group. And it is a key part of building the community and asking relevant questions. And this is just a bit of a slide to show that we've done several different projects as a Lung Health Equity Committee, but I'll focus today on the implementation of lung cancer screening because that is of direct relevance to our country. As I mentioned earlier, lung cancer screening can reduce mortality by 20%. This is a huge opportunity in terms of reducing mortality for the cancer that causes the most deaths in our country. We are rolling out lung cancer screening across almost all provinces and territories at different levels. So therefore, we need to understand from an equity perspective, are we rolling this out in a way that'll increase the stack of inequities, or can we go in with an equity first lens and do it in a way that is structurally informed? And we did this really by asking many questions over a series of years, and I'm happy to take our time with anyone after today to talk about that research. But at the very fundamental level, we were asking people living with low income, and this is back in 2017, what do you think about lung cancer screening? And this is meeting people where they're at. Seton House is the largest homeless shelter for men within the city of Toronto. Going to meet them where they're at, I remember spending 2 or 3 days just sitting at the location so that people would become familiar with my face before even talking about the research question or research study. When people were familiar with me, they were more trusting, and they would have conversations with me about what does it mean to access care? What does lung cancer screening mean to them, and why or why not would they even access the screening if it was offered to them? In parallel, also spoke to family physicians to understand, well, what do you really know about people who are trying to access lung cancer screening, especially if they come from underserved communities? And how can we do this care better? And one of the gaps that we saw very quickly is that providers are highly competent in providing clinical care that is able to, adhere to clinical practice guidelines. But the training that was missing is the ability to have conversations that were safe and that were non-stigmatizing with people, particularly when it came to smoking cessation. And so we built out a program around what is known as trauma and violence informed care. This is a very specific approach that has 4 competencies, and it's related to understanding the impact of trauma and violence on people's choice, creating safer environments for conversations, fostering opportunities for choice, and using a strengths-based versus a stigmatizing approach. We co-created an e-learning module for primary care providers that built on these trauma and violence informed core competencies. People from the public are involved in teaching this module. And it's interesting because when we went to co-create the solution, some of the early exploratory co-design sessions that we had were around, let's build out a case study, let's build out a cartoon narrative, let's develop a video-based story. And all of them were like, why would you use a fictional character when I'm here and I can create a video of my lived experience and use that to teach a primary care provider on what they can do better? So taking their videos and lived experiences learning, we anchored it across the TVIC core competencies, and we co-created an e-learning module called Creating Safe Connections. And you will see that it addresses systems and structures in many different ways. So first, from an equity perspective, we built out a team that was focused on including people who were experiencing the most inequities. We then worked with them to understand what are the barriers that keep you from accessing care, and focused on the structural competencies that primary care providers were missing. This e-learning module is freely available. We've incentivized it so that people can receive certification and CME credits. It's available in French and English. And if we can shift the ways in which the educational structure for primary care providers is received, we've changed a culture shift and allowed them to provide better and safer care. Currently, we're understanding the impact of the e-learning module in the field. We're using different frameworks to evaluate how we've reached different primary care providers, how effectively they have perceived the intervention, and what is the impact of that learning on their practice. We've engaged across a wide variety of primary care providers, and most of them go from the pre-evaluation that we have set up at the beginning of the module to the post-evaluation. And all of them report higher levels of knowledge, understanding, and confidence in delivering safer care. What we learned from the field is that most learners, what people remember the most are the videos from people with lived experience, and that they use those videos in order to develop different scripts, in order to be mindful of their words before they speak. They think about the ways in which their clinical space has been set up, and thinking more structurally about the ways in which all of the different questionnaires and surveys within their practice are structured. What people find really unique is the idea of the patient partners, the people with lived experience being the educators on the module. And this is very different from a healthcare provider teaching a healthcare provider or a professional teaching a professional. So we flipped the paradigm completely. the e-module is available free of access. Of course, this is part of our making it accessible to all learners. It is available in English and in French. And these are some of the ways in which we are responding to root causes, minimizing system-generated inequities through co-created care. And finally, I just want to end with the why. For people who are familiar with the cancer care system, and I think this is true of any disease system, we start from a point of entry into the system to a point of exit. And in the cancer care system, this is the diagram we all see very often. It's from prevention all the way through to screening, diagnosis, treatment, and recovery. This is a very clean map of what the cancer care continuum could and should look like. But the reality is very different. And this is an infographic from a patient partner group when they went in and they spoke to people who have been diagnosed with cancer to understand what's your lived experience of just receiving a cancer diagnosis. And what you can see is just the first step from suspicion to diagnosis is so highly complex and complicated. It is anything but a straight line with single blocks. And through each of these, who you are, where you live, level of income you have, all of these create cracks within our care system through which people are falling through and receiving, as in this example, a diagnosis at a later stage. So therefore, we need to understand, using a relational approach, how are people experiencing care? We need to think about this structurally in terms of who's entering the engagement process, how are they experiencing health outcomes, and ultimately, how can all people have a better healthcare experience? But to do this, we need to shift power. And I will leave you today with a quote from one of the patient partners in the Lung Health Equity Advisory Committee, who has since passed. Her name is Marlene Rathbone. She's one of the first people who I partnered with in my research program. And these are her words: to just be kind, be compassionate, and listen, because very often we can change what we know just by listening. With that, I'll stop sharing. Thank you for listening to my presentation.
Thank you so much, Ambreen, for that presentation and for walking us through the work that you've been doing related to kind of system generated inequities and kind of getting the patient group set up and the challenges of kind of implementing critical poor kind of in that work and for sharing the research on lung cancer specifically. And so thank you for that. We'll turn it over to some questions now. And so please feel free to put your questions in the chat. And you may ask them in French or English, and we can help sort that out. So whatever language you're most comfortable with there. And we'll see if anyone has anything in the chat yet. The challenges that you talked about in terms of building community, and setting up that group. Can you maybe walk through just a few maybe challenges that you ran into? And obviously, it's the challenge, but also the reward of kind of working in this way is that it does take time, like you mentioned, and having that personal, trying to form that personal relationship is so important to not only building trust, but kind of helping to build that community. So just maybe if you can elaborate on any your experiences with that and just any challenges that maybe you kind of came across and kind of how the group overcame those.
Yeah, thanks for that question, Rob. It's a really interesting one because I started this research program in May 2020, and that was the height of the COVID-19 pandemic. So as a researcher, community-based researcher, I was very used to being in community settings in order to just break bread, spend time in community, and build those relationships. The shift to a program of patient-oriented research at the start of the pandemic was quite challenging, because how do you develop relationships of trust through a virtual space where you are no longer face to face? And I think we had to get really creative. But one of the things that was super helpful was having long-term relationships in the community already. So as I mentioned, I was already in community settings. Some of my relationships went back 8 to 10 years, and I could send an email, send a text, or just pick up the phone and call someone and say, hey, would you like to have a conversation about this? So those long-term embedded relationships is really what I banked on to be able to meet with people virtually. Also, my program of funding, very generous funding from the Transition to Leadership Stream Fellowship, allowed me to purchase digital devices for members from the public. So those who I knew had digital access barriers, I was able to purchase devices and send them over to them so that we could communicate virtually. The long-term relationships, the funding for devices, the 3-year grant. So it was a 3-year grant. I think the length of the grant was also a huge enabling factor. Gave me the ability, the runway to focus on relationships before focusing on work. And I think that's a very, it's something that's very under-recognized in our current research landscape, where if projects are 6 months or a year, there's just no way that you're going to build in those relationships in a meaningful way if you don't already have them. So I would say those are the key pieces that really allowed my program to work very well, and to build those relationships, bring them in virtually, have those conversations, and co-create different interventions.
Amazing. Yeah, absolutely. And you're so right in terms of that infrastructure support, having that in place to be able to, take the time to do the groundwork is definitely, so needed and so crucial to kind of having that success in whatever the project might be, right? And so one other maybe kind of related question, and then I'll see if there's others that may have some questions there. So much work now post-COVID, especially, is done virtually, and in one way it's poses some different challenges because you're trying to build these relationships kind of in a virtual environment, but on the other hand, you're also able to kind of extend the reach of who you may be able to get to across the country, internationally. So some amazing opportunities there as well, both for researchers, but also for patients with lived experience, and patient partners looking to get involved in some of this work. What challenges or what ways have you found in working in that space that have been beneficial to kind of trying to build these relationships, or helpful when kind of reaching out to somebody new, or connecting kind of initially with somebody looking to bring them into a research team kind of in this virtual environment?
That's a really good question as well. I have to say, if you would have asked me pre-COVID, I would have said digital is just not possible. You need to sit with people, because there's so many ways in which sitting together is such a powerful experience. So I would have told you a couple of years ago that it's not possible to do this work virtually. But I've been shifted by the pandemic, and actually it can work super well. But it can work super well if you ask people what will work for them. So asking people how they can connect, what resources do they need to connect, what will make it possible for them. This can include different hours, different times of the day. What's been super interesting for me as an observer is when I connect in a virtual space now, and in particular, if it's interdisciplinary, so I'm bringing in policymakers and providers and people with lived experience. People with lived experience can have the opportunity to be driving back from work, or just keep their video off because they don't feel like having their video on. And they can contribute via chat, instead of their voice, or they can share notes afterwards. It's opened a whole new multimodal way of bringing people in to conversations that I think people experience as safer for them if we enable that setup. The other piece that I was going to say, and it's just slipped my mind. It'll come back to me. It's just super important to be very conscious of how you're going about it and asking people and meeting them where they're at.
Yeah, great point. Thank you. And I see a few other questions in the Q&A section, so I'll ask those here for you. So one of the attendees wanted to know, can you please discuss compensation issues for patient partners engaged in research as members of the research team, as opposed to a patient with lived experience as participants in the research?
Thank you for that question. And I think this is the key difference between people with lived experience who are informing the data that's being collected because they're the study data set, and therefore they're participants. So we go through research ethics board application, we've submitted a protocol, people provide their informed consent. Usually as part of the ethics approval, there will be a discussion around the time commitment that people need to do and the honorary that they would be provided as a result of being a participant in the data collection. As a patient partner, people are informing how we design the study. So they're part of the research team like me and anybody else. There's a standard CIHR compensation guideline, which I follow in my lab. That's $30 an hour. And they receive that compensation just like anybody else who on my research team would contribute per hours based on a project. So I think there are very different ways in which people are engaged as participants as part of the study data, and as partners, people who are designing the research study as members of the research team. So they're two different scopes and different institutions or regulatory bodies set up how they should be compensated.
Great, thank you so much for that answer. Another question in the Q&A is, how can a researcher without previous contacts find patient partners to join a research team?
I think there are many ways to go about patient-oriented research, and I would say the way I do it is not the only way to do it. There are many people who do very good patient-oriented research. From my perspective, I am an equity-based researcher who works on the margins, trying to build in research programs, research questions, new health interventions from people who've been most excluded. And therefore, that relationship building long-term is really key. So if you are a person that wants to do equity work, then the relationships come before the work. And I think community expects that long-term relationship with reciprocity and accountability. I know people who do really good patient-oriented research, which isn't from an equity lens, and those are structured slightly differently, but I wouldn't be able to comment on those. So from my perspective, if you're doing patient-oriented research that has an explicit equity focus, then we need to take a bit of a pause and spend time in community settings. As a patient partner once taught me, people need to have 100 cups of tea with people. So have those 100 cups of tea in the community so that you can have a relationship, and that pause needs to be built in, because otherwise it really sits on the boundary of tokenism and parachuting into communities to ask a question and parachuting out, which will make communities put up their guard right away.
Great point there. Related to the equity piece, there's a question around, are there any equity considerations for compensation?
100%. And I can give an example from my own research program. So when I started off, I said it was in May 2020, the height of the pandemic. I work at Women's College Hospital. We didn't have policies that allowed for us to purchase devices and give it to people. And we had to rewrite those entire policies. And I had to work with the institution to do that. So when my grant says I can do this, you have to agree with the grant because that's why they gave me the money. So even the institutional pushback, or no, people can borrow the device, but they need to give it back. You can push back with institutions. So similarly for patient partner compensation, the only guidelines we had were gift cards and for Amazon. And for people who are experiencing housing insecurity, an Amazon gift card really is a very inappropriate choice to even offer. So again, working with people from the public and understanding, well, what are the ways in which you would like to receive compensation? So within my lab, we've built out a whole template. Some people like to receive a check at home. Others would like a gift card. We have a whole choice of gift cards based on where they live. They have different preferences. Some people don't want to receive compensation more than 500 because it has different implications. So they can ask us to hold their money. Again, working with people to understand what are your compensation preferences? And the onus is on me as the person who's holding the funds and working with an institution who's dispersing the funds to be able to figure out how to meet you where you're at and what you need to enable good participation and contribution from everyone.
Yeah, great points to consider for sure. I think we have time for one more question. And it's what are good sources of funding to do pre-research engagement activities?
I think we have a bunch now compared to before. So in a lot of feedback that my colleagues and I in the poor community have given back to funders is the idea that relationship building cannot be taken as an afterthought or something that is after budgeted even. It's an ongoing thing. So I know the Ontario Sport Support Unit has a capacity development fund where you can engage with people to build out questions. CIHR recently had the grant call just closed last week, but it was a Partnering for Impact grant. Again, you can work with people to develop relevant ideas. I also received funding from the Canadian Cancer Society, and they did this brilliant approach, which I super appreciated last year, which was phase 1 funding for $8,000, which was competitive. But if you got that funding, it meant you could take that money to work with people to develop the full grant. And then the full grant was awarded as a phase 2, also competitive funding. So I think funders are recognizing, and there are more and more opportunities to see these kind of funds becoming available.
That's good news. Good to hear that it's expanding. Before we head out, I just wanted to give a reminder to we have some fellows that are on the call, and they'll be hanging out for an extra half an hour to be able to kind of have a little bit of one-on-one time with Dr. Sayani. So just a reminder for those fellows in the room to hang tight. But for everyone, I want to thank you for being here today, and thank you to Dr. Sayani for the great presentation and taking the time to answer the questions that were in the chat. And the webinar will be posted on our YouTube channel. And we hope to see you at the next webinar, November 26th with Dr. Stuart Nichols. And again, thank you so much, Dr. Sayani, for your time today. Bye, everyone.